Sunanda KUMARI.
Good afternoon, one and all. My case is when retina rebels, a case of neovascular glaucoma in a diabetic patient. Neovascular glaucoma is a potentially blinding condition characterized by formation of new blood vessels on iris and anterior chamber angle. It is commonly associated with diabetic retinopathy, central retinal vein occlusion, and ocular ischemic syndrome. Early diagnosis and management are essential for preserving vision and prevent complications. Case details. This is a 59-year-old male, known case of diabetes mellitus type 2 and chronic kidney disease, presented with complaint of 1 week of painful vision loss in left eye. He was diagnosed as having diabetic retinopathy on his past ophthalmological examination and advised for required management. But he denied treatment and lost to follow-up. He had history of cataract surgery in both eyes 8 years ago. There was no history of trauma to his eyes. On ophthalmological examination, vision in right eye was 612 and in left eye it was hand movement. Other finding in right eye was normal except fundus, where changes of the diabetic proliferative retinopathy was seen. And in left eye, there was circumciliary congestion and corneal edema was present. In iris, there was neovascularization. Pupils was semi-dilated and reaction to light was sluggish, and intraocular pressure was 49 mm of mercury, and on gonioscopy, Cephas grade 1 with neovascularization of angle. And on fundus examination, there was changes of the proliferative retinopathy with cup disc ratio of 0.5. Up to this examination, patient was diagnosed as a case of neovascular glaucoma. So for management, for elevated IOP, intraocular pressure of the patient was treated with intravenous mannitol with anti-glaucoma medications. Topical steroids and cycloplasics was also administered. He was also followed up with the endocrinologist for his glycemic control. He received an intravitreal injection of the bevacizumab, but desirable IOP was not achieved, so trabeculectomy with mitomycin C was done. This is a picture showing the vascularization along the pupillary margin in left eye. What is unique in my case, this patient was previously diagnosed at early diabetic retinopathy stage, which can be managed easily. But this patient showed negligence and lost to follow-up and presented when jumped to the dreaded complication. Clinical implication, diagnosis of neovascular glaucoma can be made clinically. It is essential to examine the iris before dilatation for easy detection of the neovascularization of the iris. Neovascular glaucoma secondary to PDR is a challenge to treatment and result in guarded prognosis. Surgical therapy is needed in advanced cases. Take-home message, this case tells about the importance of the regular screening and follow-up in diabetic patient to prevent dreaded complication. Control of neovascular glaucoma in a diabetic patient is multidisciplinary approach which include medical and surgical management. Early detection and aggressive management plays an important role in the visual prognosis. Thank you.
So well presented. So I have a question. Did you laser this patient?
Yes, sir.
So in your entire presentation, I did not see any part where you lasered this patient. This patient has PDR, right?
Yes,
Yeah,
sir.
at least.
Sir, we don't facilitate to a laser, so we referred the case up. We manage only in the intraocular pressure, sir. Sir, in neovascular glaucoma, management include two-step control of IOP and control of ischemia. We don't have facility to fluorescent angiography or OCT or laser. So after controlling IOP, we referred the patient to the retina specialist.
So the next question is, would doing a laser before trabeculectomy or any filtration surgery for that matter, would it increase the prognosis or decrease the prognosis? It would make the prognosis better, you know, because
Yes,
essentially when you laser the patient, the NVIs are supposed to regress. So now
Yes.
a patient with an aggressive NVG would rather act like a patient of PACG, depending upon what amount of closure of angle has already happened. So if you ask me, if a patient of NVG comes to me, and even if I'm sitting in a peripheral center where I don't have the facility of laser, of course I will start him on maximum tolerable anti-glaucoma medication, and I'll send him for quick laser within a week or so. And in the meanwhile give an anti-VEGF injection so that there is quick regression of NVI, and then plan this patient for a subsequent filtration surgery so that the success rate of the filtration surgery itself goes high. So when you, quite honestly, if you ask me, though the literature says that the success rate is maybe 85% or 90% in 1 year, practically I have not seen any surgeon replicating 90% success rate in an NVG case, that too without lasering the patient first.
Yes.
Yeah, it will worsen the patient. So you have to laser the patient first. Otherwise,
Basic.
after TRAB, it is very difficult to laser also. You don't want to touch the cornea. You don't want to put the lens over the cornea. You are very much perturbed about damaging the bleb, loosening the sutures that you have applied during the TRAB. So it's laser first and filtration surgery second. That is the newer concept. Of course, the older concept was to treat the IOP first and then maybe keep on lasering the anti-VEGF. So, please.
No, you have to laser. Basically, basic treatment.
It has to be lasered.
Do a angiogram, do a
Preferably
laser.
it has to be lasered
Treat
before the
the-
filtration surgery also. Eventually, everybody will say it has to be lasered, but preferably before a filtration surgery.
Thank you.
Thank you.